Good morning, everyone. Thank you so much for joining us for our final installment of the 2017-2018 nursing rounds. And so we're very excited to have Elsie Tan leading the session this morning on interdisciplinary professional education. And so she's kindly invited some of her collaborators as guests for the panel. And we're recording this session because although we have a smaller audience today, we know there's lots of interest in this session, and so there's people that have already sent requests to me for the recording. So without further ado, I'm going to pass it off to you and let you introduce the guests.
Okay, yes, I will. All right. Thank you very much, Mary, and good morning, everybody, and thank you for coming so early in the morning, especially our guests, after the long weekend. I do see some new faces in here, so I just want to get a sense of who you might be.
Sure. So I'm Erin Johnson. I graduated in grad program, nursing program at UCNT. Okay. I'm also finishing up my master's degree here. It's an MSN degree.
Great, thank you.
And no problem. And I'm doing my project on IPE. So.
Oh, wonderful. That's what you're. Okay, and I know there was another fellow that was in here and he's left, so I suspect he's also a graduate student, perhaps. I saw him come in and he left. So anyway, good morning, everybody. And I'm sorry, Raji, and Catherine, if you can't see me. I just have to stay close to this mic. So I want to first introduce my guests who joined me today. It's hard to do IPE without bringing in my collaborators as well. So first and foremost, it's Sue Murphy from the Department of Physical Therapy. Many of you know her already from Faculty of Medicine. And Larry Leung from Pharmacy. He's a lecturer, and he has lectured with us along with Jason previously in some of our courses, so he's familiar with nursing. And Carrie, someone whom I've worked with for a very long time. She's a coordinator at the UBC Health and also assistant professor at the Dentistry School, particularly the School of Hygiene. Both. More hygiene. Cross appointments. So today really we're just talking about collaborative practitioners, but more importantly around what our programs are doing and how we're preparing our students in the interprofessional realm. So I'm going to give you a little bit of history of how IPE came to be at UBC. We'll talk about some of the resources that's guiding the work that is taking place. And also then our guests will speak to each of their programs, and then predominantly to open up for dialogue, because I think the models that have been taken up is wonderful in supporting each other and also giving us opportunities to look at how we can enhance our own learning environment in IPE as well. And feel free to ask any questions at any time of us, and because really this is about dialoguing at the session. So just to be sure that we're all on the same page and how we define IPE is that IPE is a situation that occurs when two or more professions learn with, from, and about each other. And that was developed back in 1997, and the definition has been revised in 2002. So that we're also not confused with intraprofessional and interprofessional. Interprofessional is how we define as perhaps, give nursing as an example, where you have LPNs, psychiatric nurses, and then we have RNs, so that's what we call interprofessional. Also not to be confused with interdisciplinary, and the difference is that in disciplines, they're different from professions, and that professions are credited, and that graduates need to be licensed in terms of licensure examination and so on. And also teamwork is often used and confounded with the notion of interprofessional collaboration. Again, teamwork is a much broader term that does not always encompass what we call the competencies in interprofessional education. And so UBC Health, at UBC, as you can see, we have 17 health programs as partners in the UBC Health, larger UBC Health programming. But prior to this, we started off as a College of Health Disciplines, really the vision of Dr. John Gilbert back in 2000, and it came to fruition in 2001 as a College of Health Disciplines. I know Catherine sat in some of the committees, so that Wendy and myself right at the inception. And since then, and actually back in 2001, we only had about 10 programs as part of the College of Health Disciplines. And since then, as you can see, we've now grown to 17 programs as part of UBC Health, and we engage with each other at various levels and at various times and at various contexts in learning environment. And I think what's also important is that College of Health Disciplines then, as it was known, and the name change occurred at 2000 and where are we now, 17, 15, 16? Yeah, 2015, really came to be at UBC Health. But prior to that, the College of Health Disciplines really was the, what I would see to be the eminent thinkers in interprofessional education. And you'll see that the first block on the far left on your side, the British Columbia Competency Framework for Interprofessional Collaboration, really came to be under the direction of Dr. John Gilbert. He and his team put this together, and it was 2008. And at the same time, the accreditation for interprofessional health education was in the works. It was a project funded by Health Canada that then really looked and examined the competencies. And many of the health programs were involved in part of this project. And I do have the documents here if you wish to see hard copies of them. And Dr. John Gilbert was also part of this team in envisioning and pulling together this work. And then at the same time during this period, or a little after, the WHO came up with this other document called Framework for Action on Interprofessional Education Collaborative Practice. Again, Dr. John Gilbert, and now Leslie Bainbridge was also part of this team that really evolved and brought this to light, that then at the same time led to the National Interprofessional Competency Framework, which is now, this came out of partially out of this document, that really now is leading the work and the competencies that programs that you will see shortly from pharmacy and dentistry have taken up to guide their work and development. And this phase 2 really came about, and these are the guidelines for programs to take up, guidelines for faculty, guidelines for outcomes, guidelines for students, and guidelines for practice in terms of what they should be considering in terms of developing their own IPE programs. So moving from there, this is the big competency, the interprofessional competency that we look at, and there are 4 key areas: role clarification, interprofessional conflict resolution, team functioning, collaborative leadership. And within these, there are documents that give us the specific guides in terms of competencies and exemplars of what we might look for and look at, and benchmark in which we evaluate our students. And so a lot of programs beginning to take this framework up and to guide their work. So on that note, I'm going to pass the torch to Sue for her discussion around PT. You want me to come over there? You can come over here. Absolutely.
Hey, so thanks, Elsie. That was a really good synopsis of how this all came to be in the process. So as far as the physical therapy program goes, we've always recognized the importance of interprofessional, and it's kind of been an interesting journey for us because, as some of you may know, we used to be up here on this floor with OT, and so the students used to do quite a bit actually with the OT students. They used to do anatomy together, they used to do neuroanatomy together, and so on. But when we actually moved over to the Friedman building in 2008, a lot of that kind of fell apart just from pure logistical reasons. So we had to be a lot more really thoughtful about how we were embedding these interprofessional experiences into the curriculum. So the way we've done this is we've created a 1-credit course, which is our 576 course, and it's really the last course that the students take, and I'm using that word loosely, because really what this course does is it collects together all the interprofessional experiences that the students have had through the program and just looks at, have you actually had interprofessional experiences where you've thought about the different competencies, where you've experienced it to different levels, some interprofessional engagement. And if there are things missing at that point, then they have to make up some interprofessional experience in order to graduate. So the 1-credit course really looks at basically their IPE passport. And this is something put together by UBC Health. I think most of you are probably familiar with the passport, where the students get points for different activities. So I haven't put the number of points up there right now because I'm not actually quite sure what we're going to say for the next year because we keep shuffling this a little bit. But I know at one point it was 80 points, but now we've got a slightly different rubric. So we basically look at different things that students do, and these are the components of the 1 credit course. So first of all, we look at the integrated curriculum activities. So this is things such as the iEthics course and those types of things. There's going to be a new professionalism one, the e-health modules and so on. So we look at whether the students have completed this. And the way we've integrated these is to actually write these activities into some of the course syllabi. So for example, iEthics is part of our 516 course, which is our professionalism issues course. So it's actually a required session in there. It's on the course timetable just with everything else. So it's very much integrated into that. So we look at their attendance at the integrated curriculum activities, all of which are mandatory. We look at we also embed some intra-curricular activities. So for example, one of our pre-placement courses has a session on conflict and communication where we bring in actors and do some simulation and role play and those types of things. And we do that with OT and speech. We have a walking aid session with OT because that's a very natural fit. We have neuroanatomy. On neuroanatomy course, we actually have dentistry. We do that with dentistry as far as the lab sessions go, so they actually work collaboratively together in the lab. We have an interprofessional clinical education reflection series, or the ICERs. And for this one, the students, when they go on to clinical placement, they have to do a weekly reflection on clinical placement. The placements are 5 weeks in length. And then the students actually take one of the interprofessional competencies and comment on that and write a reflection around that, so that by the end of the program, they've reflected on all 6 interprofessional competencies, where they've seen it, where they haven't seen it, barriers that they've seen, experiences that they've had with that. Also, during our orientation week, we have a 1-week orientation before students actually start our program, directly before the Labor Day weekend. So we do some of those activities with OT. For example, sessions on just the concepts of patient-centered care, social determinants of health, the ICF, etc. So some of those core competencies we have with OT. And then also in the IP Passport, they have some optional activities, things such as the health mentors or any other interprofessional activities provided by UBC Health, or in some cases by other opportunities. So those are embedded in there as well. So it's just really, the course really provides a framework for just collecting together all the information and making sure that students have actually completed that. So just some of the challenges that we've noticed with this. We're all very committed to the concept. However, it's not sometimes as easy as you think to actually bring this all to fruition. So I would say by far, from our perspective, the biggest problem is timetabling and scheduling. It is incredibly hard to actually even get 2 programs together who actually have free time at the same time. And it sounds ridiculous because surely everybody can shuffle things around to make this happen, but actually that is huge. And I think Carrie could probably attest to that from the integrated curriculum perspective too. Actually trying to get people, whether everybody is available, is actually huge. So that's the biggest, I would say that's probably what stops us doing more of this. It's just logistics, which I don't know how we solve that one. A second issue is student buy-in, and I think this is really, really important. Students enjoy the interprofessional sessions, I would say, as a general rule, and they're quite up about the whole thing, and they love chatting to their fellow students in different professions, and, oh, I didn't know a nurse did this, I didn't know a pharmacist did this, and they're quite into it. But I sometimes think they miss the relevance to the actual curriculum. So, for example, in my 516 course, when they go off to do their iEthics in the middle of the professionalism course, it's sort of like, well, I don't know why we're doing this, but we'll go and do something fun over there, and then we check off and it's completed. And it's sometimes hard to actually link it back to, well, the reason you do this and how it relates to the other content in the course is this, this, and this. And of course, it doesn't always help either that I don't necessarily go to those integrated curricular parts, so I don't necessarily know what they're teaching other than in a big big framework. So there's a little bit of the linkage piece that sometimes is a little bit tricky. The other issue that we've noticed a little bit is appropriate facilitation, because it's not that easy for PTs to suddenly start facilitating group work, for example, in role play or whatever, with a load of speech language students or OT students. It's like, okay, what do I need to know about that? And I sometimes think it's easier than people think it is, but there's sort of that barrier of, oh, it's a different lot of students, I don't know what I need to do and say. And even though the facilitation skills are really facilitation skills, and it doesn't actually sometimes matter who's on the other end of the facilitation, but it is a bit problematic just because of that gap. So I sometimes think we need a bit more faculty development, even though we do always do an orientation and those types of things. It is a little off-putting, and I know I've been off-put too when I'm standing in front of a load of medical students. It's like, okay, how do I say this in their terms, and what do I need to do? So there's definitely a faculty development piece. Thank you.
Thank you very much, Sue. I think we have Larry.
Perfect. So yeah, I've been. Thanks, Elsie, for the invitation. I've been really lucky in my current line of work to get to work directly with nurses and physical therapists and physicians, and so it's something that I get to live and breathe every day. And so, okay, I'll just talk louder. So something that I live and breathe, and so it was with that mindset that we really wanted to create that culture shift. So I really like what you were talking about in terms of changing the student's mindset. And so historically with pharmacy, most of the interprofessional education occurred when students were on their experiential education. And so as our program started to transition to the Entry to Practice PharmD program, it was a really good opportunity for us to revamp interprofessional education. And so when we were asked to come on to co-lead interprofessionalism, we had several asks. So first off, we didn't want faculty members or somebody who's leading this to do it just off the side of their desk. There had to be dedicated time. So the first thing we did in our faculty was to create an actual position for it that had responsibilities, roles, all of those types of things. And so IPE is considered a curricular theme. And so myself, I'm a curricular theme lead. It's built into my portfolio, so I don't feel like it's something that's off the side of our desk, because as we know, it is a really core learning objective for students. So that was a key thing and a key learning point for us and our faculty. The second piece was we wanted it housed under something. We didn't want IPE to be a floating entity that kind of, again, was just side of our desk. And so for us, we decided to house it under the Office of Experiential Education, under that portfolio, mostly, again, because IPE typically does occur on experiential rotations. So in that sense, being under a department really helped to provide more practice support. So we have an administrative senior program assistant, for example, that does a lot of our planning for IPE as well. So we're really lucky in our faculty that there is such a big support for IPE. And so we have interprofessional education leads, as I mentioned, as part of our faculty. It's housed under the Office of Experiential Education, and we also developed an IPE advisory committee where heads of different programs will sit on this advisory committee. We only meet once or twice a year, and it's really to inform on, is the program going in the right direction? Do we like the activities that students are participating in? And so we'll have people as part of courses participate in it, people who are in charge of assessment, in charge of technology and education. Those are the types of people that are represented in the advisory committee. And then we also have a student representative from each of our 4 years that will sit on the IP advisory committee as kind of like a mini focus group that will provide us feedback once or twice a year. So that has been really effective for us. We've just done that in the last couple of years. And so as part of our idea of sort of shifting the culture, we wanted students to kind of live and breathe this on a daily basis. What was really funny was previously our students would say, is this IPE? And it's like, you're doing stuff with other health disciplines. We shouldn't have to ask these questions. And during experiential, for instance, we have IP activities, and students will will basically put on a hat and say, okay, I am now doing IPE. I'm going to do my activity. I'm going to shadow another health discipline. And then IPE is now over. I take my hat off, and then that's it. So we really needed to change that culture as well. And so for our students, that was a really big piece. And so we developed, as Elsie already mentioned, a competency-based curriculum that was mapped to not only the CIHC competencies, but all of those learning objectives that we had were mapped to CIHC, which were then mapped to our Faculty of Pharmacy across Canada outcomes as well for accreditation purposes. So all of our learning objectives are mapped to all of those outcomes. And as part of our curriculum, we essentially have embedded, non-embedded, and then optional IP activities, and these are all laid out in a professional practice policy for our students. So embedded activities are activities that are embedded directly into courses. And so very similar to what happens with PT, we wanted the IPE activities to be worth marks, to be worth something, because inevitably the way that it works for a lot of our students is if it's an optional activity that's not worth marks, they're not really participating as well as they can be. And so that took us a lot of time to make sure that we are embedding them directly into lab activities, into tutorials, into even courses as well. And so the embedded activities are mandatory stuff that the students need to complete. The integrated curricula that UBC Health is working on as well, that's something that's integrated into the course. We have non-embedded activities as well. So non-embedded activities are still mandatory activities. They just happen outside of regularly scheduled class time, and that's mostly due to scheduling. And so pharmacy has a program enrichment activity day, which is technically a non-instructional day. So every year, there's one day that's completely blank, that students do not have formal lectures. And those opportunities, like for instance, our first year students have Fridays off. Those are built in so that they can participate in interprofessional activities. So non-embedded activities are the ones that happen outside of scheduling class time. They're still worth marks. And so for an example, one of our best rated activities are the case-based learning activities, the large ones that we run. So we run two in second year. We run a cardiovascular case with dentistry. And so it took us a lot of work to map out our curriculum with the dentistry curriculum. And unfortunately, there was only one module that overlapped, and that was cardiovascular health. And so we do a AFib, antithrombotic type case-based learning that looked at sort of our students teaching them about Framingham risk scores, and then vice versa, the dental students teaching our students about dental procedures and what to do with anticoagulants prior to dental surgery. So we have one case for second years, and then in term 2 we run a fantastic activity again with dentistry and with physical therapy in the neurology module, and so that's a chronic pain case, and so our students will do that. What's fantastic about those activities and what we've really been trying to push for is to make it completely student run, because at the end of the day we wanted to create a program where if I left, IPE would continue. As you guys know in your program, if you stop doing it, that's it. It might stop, right? We need to have more people promoting it. And so these are completely student run. Everything's posted online, and then we run a debrief session together. So those are non-embedded activities. Those are just some of the examples of some of the things we do. And then optional IP activities are activities that occur on the passport system. So that was one of the big shifts that we made in our faculty, that our students no longer require IPE points. And that was a really tough decision for us. But at the end of the day, unfortunately, the passport, we couldn't guarantee that all of our students could fulfill the passport point requirements because we have 224 students. So, for example, in our previous program, we had about 100 students that did not have enough points requirements. And so we just wanted to embed everything as sort of mandatory curricula that students participated in, and those that were more inclined to do, they had optional activities. With every single one of our activities, we also created a standardized checklist, an assessment for all of the activities. Happy to share that if anyone's interested. The checklist is very simple. It describes the activity, it describes the partners involved, It describes a step-by-step on what to do and at what time interval, and then includes a section on this was the evaluation from our students, and this is what we're going to change for next year. So every single activity has one of these checklists along with it, which is part of our master plan. And again, the reasoning for creating that is so that when I step away, I have something to hand and say, this is our IPE program, and this is the checklist for every single one of our activities. So that has worked really, really well for us as well. So that's sort of what our curriculum looks like. This is just an example of, sorry, it doesn't appear very well on here. It's a large poster that we have in terms of us mapping out with the CIHC competencies throughout PY1 to PY4. So we just mapped out which learning objectives would occur in which year, and then each one of these ones in a larger document are then tagged to our AFPC outcomes. And so that's just sort of one of the first things that we did for IPE.
Thank you there.
All right.
Okay, Carrie. Next. Too much time. Have here, Elsie.
5 minutes, okay. So thank you for having me, and I would like to give you a little bit of background because much of what Larry and Sue has said actually applies to dental hygiene as well. One of the things you're probably wondering is, how does this fit with dental hygiene? And the UBC program is actually one of 3 dental hygiene degree programs in Canada. And so the vision for our dental hygiene graduates is to look at practice settings in a different way. So looking at more role emerging. So really trying to envision where dental hygiene can go in terms of the workforce. So it's a little bit different because a lot of people think, oh, you're just going to work in a practice setting, but that's actually not kind of the culture that we try to create in our program. And to give you sort of an overview of the workforce right now, about 95% of dental hygienists work in sort of this traditional clinical practice setting, and 5% work outside. In the province of British Columbia, myself and about 300 others are licensed as independent practitioners. So we can go and open a practice. Many of my colleagues work with First Nations. We work in public health or education. So this is kind of the vision for our practice. The other challenge, as Larry alluded to, is that the practice setting is often very siloed. And so there's not an opportunity necessarily to be co-located with a lot of other health professions other than dentistry, which is sort of intra-professional, not interprofessional. And so part of the sort of culture is to, let's create your team. Who should be on your team? Do you know a pharmacist? Do you have someone that you can call if you have, do you have a relationship with your patient's physician? Can you bounce back and forth some ideas? Now, I'm from up north. The community is very small, so, you have a neighborhood party and you've got all your your healthcare providers are there. Down here, it's a little bit different, so you have to envision that. So that's, I guess, the foreground for so the way we try to approach IPE, which is within dental hygiene, we're a small faculty, so it's much easier. We have our director is very much on board with this, and so we have embedded it much like pharmacy has. We have a national dental hygiene competency framework, and we have mapped the CIHC competencies to that framework. And what that has done is, as you know, within your national framework, it doesn't sort of suss out all of the various levels of what interprofessional collaboration looks like. So the CIHC competency framework helps to kind of deconstruct those for students to be able to envision, well, what does this look like in terms of communication? What does this look like in terms of shared decision making? So much like PT, we have many of the activities like iEthics and Indigenous cultural safety and e-health and help me out. Professionalism, thanks, and now resiliency are integrated into the course syllabi. So we have master courses within dentistry and dental hygiene. We have one big omnibus course each year, like 210, 310, 410, and it's the same for dentistry. And within those courses, we have modules, and our modules focus on different things, and it's a spiraled curriculum. So we look at, I teach in communications theme. So in dental hygiene, I do a little bit in year 1, and then I do a lot in year 2 because dental hygiene actually devotes an entire year to all aspects related to communication. So I have them for the full year. And then in dentistry, I teach in 410, 2 sessions around client-centered interviewing and team functioning. And then in 420, I'll teach another 6 sessions, and then 430, I'll teach another session when they're actually working with patients and they're looking at shared decision-making and collaborative care. So it spiraled like that. In addition to the integrated or embedded activities in the course syllabi, we have optional activities. So in the syllabi itself, it says they must participate in one IPE activity. And that could be something that UBC Health supports, or it could be something that, like there's a number of sort of flexible activities on the passport that they use out in community practice. So they take one of those and complete that. In addition, because there's a few of us that are really keen to make this work within the faculty, I actually run a motivational interviewing session with SLP and audiology. And to make that interprofessional, we actually use case-based learning, where the students then, we have an Audi case, we have an SLP case, and we have dental hygiene case. And that's where you need the collaboration of other professionals, because I can't create those cases. I can't envision that. So Lisa Avery and Marcia Choi and I got together and we looked at building those cases for that session. And then in addition, there's a passport activity that we've actually embedded within a 210 course for dental hygiene, the eating, feeding, swallowing panel with OTPT nursing students come to ASLP. And then to follow up that panel, Diana Lynn brings in some of those panelists into the class and they do a debrief after that panel. So that's an example of how they're sort of leveraging what's happening on the passport but also embedding it in the course. Optional activities, the students are usually very good about completing their IPE activities, and we've had many keeners in their second year complete all of the activities for the entire 4 years, but then we try to discourage that because we want them to have, you know, a little sort of, because they experience it at different levels as they go through their program. So it's really important for them to be able to reflect on what they've learned and then apply it at each year. So Health Mentors, we run a couple of workshops in the evening, sort of 5 to 7:30, rehab in the context of HIV. The PCPE patient panels are very popular with the students, as well as just this past year, we've been given the go-ahead that the dental hygiene students can participate in the VNHYI dinners with CHIAS, which is another hat that I wear, but not dental hygiene. So, so there's sort of the overview. So much like pharmacy, we've looked at mapping these across the years. Now you probably look at year 1, there's not very many things there, but to give you a bit of context, our year 1s enter right after high school. Now that's changing a little bit because we're seeing more and more students with post-secondary come into the program, but they're still quite young and they still don't have much of a professional identity yet. And many of the prerequisite courses are not specific to dental hygiene, so research, math, and statistics, and microbi and things like that. So when they actually get into second year, they really start, I mean, we're teaching them their code of conduct and things like that in first year, but they're really not starting to engage until about second year. So you'll see the competencies do ramp up all the way through the years. You can't really see this, but in fourth year, there's a lot of more activities through experiential learning. And so the students are going out into the community and working with Elizabeth Fry, and they're working with Vancouver Native Health and Positive Living. They're actually embedded right into the community, providing oral health services. And so that's a really great opportunity. And that's where we're heading right now. We're looking at structuring those activities a little bit more so. They have been kind of loosey-goosey still. And so that's where our program is heading right now, is looking at structuring those as well as the evaluation piece. You know, we've seen a lot of activities, but we don't really know, is it working? You know, how do we know it's working? And that's sort of our next phase in terms of the dental hygiene program. Okay, so some of the barriers and builders, and I stole that from, yeah. So first of all, it's a 4-year program. That's a big plus right there. We have time with the students. We are getting faculty buy-in. I think in the dental hygiene program, faculty buy-in is really strong, and it's a smaller program, although we do have a couple that are holding out. And then further to the dentistry program is much larger. Like you can sort of imagine that dentistry is much like medicine. So we have these omnibus courses. We might have 60 instructors in one course. So it's really, really hard to embed that culture through all of those. Definitely faculty development to support the IPE facilitation, and the level of students, because our students are quite young. You know, it's difficult sometimes to figure out the right fit with the other students and where they're at and where they can function, but I can tell you, like with the SLP and audiology students, we have year 2 students that are working with master's level students essentially, and they seem to rise to the occasion. So you just never know. It sometimes depends on the content. And then the timetabling, as everyone's mentioned, is always a struggle. And so looking at now, I'm already planning for the fall and next spring, trying to get together, looking at potentially doing that workshop that you guys do with dentistry and, you know, PTOT, but just trying to, I've got the funding, I just don't have the time yet. And so it seems like that seems to be the big struggle. So.
Thank you, Carrie. And I do apologize to our panels and guests for this drilling that's happening. Didn't think they would start this early in time. They were a little bit early. All right, so the School of Nursing. Many of you are already very familiar with the activities that are embedded within our School of Nursing. We all began first with the extracurricular activities under the passport system. Students, you know, selected a menu of activities and events that were hosted by UBC Health, primarily because we have an accelerated program. So in 18 months, we are hard and fast in terms of finding the space and time for students to actually engage in IPE. So the best move forward is for us to tap into the resources that are available, and UBC Health was a key resource for us. And so we developed the IPE passport at 120 points, which was the most minimal points that students could engage in. So that could mean sometimes 2 events or up to 3 events over the 18-month period. And so with that, all the activities included, you know, when we first started was the Healthcare Team Challenge, CHIAS activities, Seed to Sky Phaser Camp, that was very well received, and students really enjoyed that. Health Mentors program, which was part of and embedded, and that's still in discussion whether it should be, and I think for some of you, primarily because Health Mentors program can only support a finite number of students. So not all students from all programs can participate. It's a wonderful program. We all wish they could accommodate the 950 students, but unfortunately it's based on funding, and that model is being looked at as we speak. Pharmacy hosts a couple of sessions, the contraceptive conversation and medication reconciliation that students in the past have engaged in. But for this year, as we're going through revision, we've suspended all what we call extracurricular activities and really participated only in the integrated curriculum components. We've now since eliminated the 120 points because of the integrated curriculum, just because, again, in accelerated programs, space and time and scheduling is so finite, buy-in is sometimes a bit challenging for us at this point. So right now in the School of Nursing, we're engaged in IFX eHealth, Indigenous, sorry for the misspell there, cultural health, conflict management, resiliency, and professionalism. There's one more up there that I have not put up because I think we're going to put that on hold, which is the IPC on the run, interprofessional collaboration on the run. It's modules that our practice partners have taken up for their staff and for practitioners, and now they're going to open it up to students. And so in some courses, some faculty have embedded the first module into the very beginning course, and right now they're looking at opening it up for it as part of the integrated curriculum. So at the moment, we're sort of sitting status quo with integrated until we are settled with the revisions before we open up and examine what other opportunities there might be for our students. So strengths and areas for enhancement. Fortunately for us, CASN, there's now going to be a new set of competencies coming out. We just finished reviewing the competencies of CASN. They're rewriting all the competencies in all different areas. So there's one for interprofessional education. So we're making sure that we're mapped onto the CASN. CRNBC has some very fundamental foundational components. We're mapped onto that absolutely, and our program outcomes is mapped onto it as well in one of the outcomes. Because we're an accelerated program, we have to be very conscious and very careful in how we embed and look for the best link possible so that it really enriches the students' learning. Faculty to support facilitation. For the principle from UBC Health is for every 40 students, we should be committing one faculty to the facilitation. So we have 120, so that's about 3, actually 240, so we should have 6. Finding 6 faculty has been challenging. We do have our continuing appointments engaging, and I know we have one in particular that have been consistently part of this team. I facilitate it here and there when they're short, and then we're hoping to, again, support other faculty and continuing appointments to be part of this team. The level of students, as many of you know, if you've seen earlier, many of the programs, such as PT and pharmacy, and I think some other programs, pharmacy, some not so much, but PT, OT, are all graduate level students. And our students are actually engaging with many of the graduate students. And it seems to there seems to be a strong and good fit. And one of the, I think, areas for enhancement is I think sometimes students do observe and have given us feedback, particularly from nursing, is that they engage in some of the events and they find that the nursing students are at a much higher level than the other students. So finding the right level of students for the right fit has always been challenging for many of us. And so that, I think, is another area that we need to perhaps focus on and enhance in moving forward. And of course, administration, having UBC Health has been a real savior for us because they do all the, what I call administrative support for putting together these programs and also for tracking for many of our students. Even though we're not part of the passport system, they're still continuing to help us track the students' engagement in any of the activities. So in conclusion, and moving forward, and please to the panel, feel free to contribute and jump in on this. I think our vision is for us to see that all health programs at UBC participate in IPE consistently, continuously throughout, rather than parachuting in, parachuting out. And it might not be all of us on the same page, but maybe different programs at different times, but that there will be some set areas that perhaps programs can be engaged in. We like to see what we're doing now to move to the next level, which is bringing it to the practice environment. We're in the classroom environment, but what we like to see is when students are out on experiential learning and field work, in our practicums, that they're actually coming together in that environment to pursue that interprofessional learning. We're also reshaping care delivery. We're starting to hear components of how care teams are coming together. We used to have care teams, you know, case rounds and so on, but I think that's starting to shift. I'm hearing words. I don't know if you have heard the same, but we're starting to hear different approaches, different people taking on leaderships. We know that in community health and nursing, particularly in nursing, I've seen that case management sometimes is taken led by a physiotherapist who is case managing, whereas traditionally it's been a nurse who's been case managing or a physician who's been case managing. So we're starting to see some of that shift. And of course the work we do ultimately will reshape healthcare services, and perhaps we can start doing research in how cost effectiveness, patient outcomes, effective teams are being taken up in practice. I think that's one area that, because we haven't quite shifted to the practice area under these competency guidelines, we haven't been able to monitor, track, and also use as benchmarks to actually carry it through to the practice environment. And hopefully that will be the next step for us in moving this IP agenda forward. And eventually that's no longer an IP agenda because it's normalized into our programs and into our way of being. Right? So thank you again to all of you, and particularly to our panel who's here. And it's very interesting, even though I've worked with so many of you, I haven't known the details of your program. So it's really valuable to have this opportunity. We'd like to open up for questions and answers, and at this point to the panel. I know some of the ideas that you folks have presented, I think we in nursing can probably tap into as well. I particularly like the 1-credit course. If we can, our next program rewrite, that's another way of looking at it, so it's embedded. Also, Larry, the competency, and Carrie, the competency framework, and how you've mapped that. I think nursing could begin to do that if we haven't already. Yeah, that's really important for accreditation experience.
There is something I learned when I used to coordinate the IHHS courses before 2015, is that many faculties and programs have a course shell. And so that course shell was used in a variety of ways, like directing studies or like this 1-credit course. And it's essentially open, free to use without having to go to Senate because you already have it.
Right.
So just kind of put that bug in your ear about that. It's just sort of a backdoor way of being able to, engage with different kinds of work.
Right.
I think the only thing I'll maybe add to that in terms of the flip side, because pharmacy was looking at, when we were deciding how to properly embed it, we were looking at a course as well. I think the challenge with the course and why senior leadership decided, and we decided not to go with it, was it was tough to mandate to students that they had to complete an activity in year 1 for a course that was technically a 3rd or 4th year course. And so we were thinking, worst case scenario, you only need 1 student to notice that and challenge it. And there's no way for us to mandate that a student had to complete these activities in order to get a grade or get a pass grade in 3rd or 4th year. That was a challenge that we had. That we couldn't reconcile, and so that's why we decided not to go that route.
Yeah, and that's why we put that course right at the end,
yes.
Because by that time they'd had the opportunities, because that was certainly a consideration.
Yeah, it's good to know.
I think that the student load is also a consideration.
Yeah.
220 versus 680. Yeah.
Right. Any questions from folks? Sure. Yeah.
This is to everybody. So how do you support faculty with facilitation currently? Because that kind of came up a couple of times.
Yes.
So that's usually done with UBC Health. UBC Health, and I'm going to wear my UBC Health hat right now. UBC Health has taken on the mandate of supporting the integrated curriculum. And this, we've recognized from student evaluations that that's a key piece. And so this year, we're actually having a workshop, a facilitators workshop, which is very robust. Now, for the resiliency curriculum, which is I'm the lead for, it's actually 2.5 days of training. So that's a big commitment, but we're working with Canadian Mental Health Commission, and so there's sort of a quality assurance piece that needs to be sort of reconciled there, because it's not our curriculum, it's theirs. But for the other facilitators, we're going to piggyback on that, or potentially some other days where we're really going to look at facilitation a little bit more closely. Thank you.
I think we looked at just changing the culture shift to one as well for our faculty members. Again, making more of a recognized piece that you are contributing to the curriculum if you're facilitating, not again something that you're doing as volunteer work. And that's something that's we've been really pushing for. So sometimes we'll have the program director ask directly for facilitators. Our IPA advisory committee is a recognized committee as part of our faculty, and then the last piece is just again just making sure that it is recognized as being part of workload. I think has been really big for us.
And I think for us, we've often tried to get people who are also working clinically, so using our clinical faculty or instructors who will also practice, because they are very used to working in a team environment in a clinical setting, so it's a little bit of an easier shift than somebody who's maybe been working in academia as a sole profession for a long time.
And for nursing, it's primarily been based on their interest and passion or curiosity in the particular area and topic. So, but we're starting to see much more interest now as we broadened it to, for example, professionalism, conflict management, and resiliency. So we're targeting specific faculty to be part of the development work and hopefully to carry through to being also the facilitator. Good question. Thank you. Wendy.
So I was interested that you said that the next stage is going to have to be research to show that it makes a difference, because I've been working in this area for more than 15 years and do quite a bit of reviewing for interprofessional journals and things like that, and it is considered to be very difficult to demonstrate that what people experience in their curriculum, regardless of how much you try to embed that in practice, actually makes a difference to how they function when they get into the clinical area as a graduate, or even that there aren't a lot of other factors that are influencing that. So I'd just be interested in your thoughts about that. I think it's a big problem.
I agree, it's an absolutely big problem, and we've been, we do have conversations about, okay, we're doing this with the best of intentions, but is it actually making any difference? Because a lot of the research, and Wendy, you would know as much better than I do, but a lot of the research that I see is really based on student satisfaction. Yeah, we had, that was really a fun session, and I really got to learn about this. It was great, but was it actually changing? Did it actually make a difference, or was it just a really fun thing to do during the day?
We haven't, I think, some similar challenges. A lot of our assessment or evaluation is based on student perception. So oftentimes it's like a pre-survey of a set types of questions, and they do the activity or they do the experiential, and then it's a post-evaluation. I think one thing that's been kind of neat that we've been doing with our Indigenous Health elective that we're now trying to look at for IPE is we've done a pre-survey pre-class, a post-survey after they've gone through the curriculum for our Indigenous Health elective, and then actually we did an alumni survey after they've been in practice for about 2 years and asked them similar questions about how that has changed practice or if it's changed practice. And what's been really neat is using that, we've been able to identify fantastic past students that are now guest lecturing in my course. That's one thing that we've tried. So it is tough. It's certainly tough.
I can't help but wonder also that the fact that we now have the national competency framework, and as that's been taken up, I mean, it took a while before it really became embedded into programs, and as programs take it up and begin to map the programs on the competency framework, we begin to deconstruct what our HAR programs have set up, and I think that might be the beginning step. There's something in that, I think, as we deconstruct, that we may come up with new questions around what is it that we really want to look at, examine, put under the microscope, and that may help build that database of further research. Where it's going to go, it's really hard, because even though interprofessional has been in the realm for a very long time, we haven't had a microscope on it.
Achieving some of those core competencies.
That's right.
It's almost impossible. I mean, conflict resolution, collaborative leadership, those are very tough things to achieve.
And not to graduation, and like mapping them through, longitudinal study may perhaps capture some of that. So
there was something I just did recently, actually. We rolled out one activity for the placement setting using appreciative inquiry, so that the students would interview at least 3 other folks, different professions, and consolidate those themes using qualitative analysis themselves, which we sort of help them through, and then come up with themes, and then come up with next steps for their practice. and we did qualitative analysis of looking at the transformative learning pieces, and that was probably quite interesting. I think that might be an approach in terms of looking at research that goes beyond sort of the students' perceptions of things, but looking at, you know, some of the transformative learning pieces that came out of it, like things like there really is a hierarchy here.
Confirming.
You know, but for a new student, you know, and for some of them, like one student says, you know, I feel like one of the practitioners is holding back a little bit. You know, one of the things that's working is this process, you know, and they're bringing that out of their observations, which I thought was really, really good stuff.
Thank you. One last question before we wrap up. Thanks, Jill.
This is about medicine, and they're involved in this as well.
Yes, as much as they can.
Just because it's so, think about the family physician, the physician in the hospital, and how tied in they are to what happens to patients. And I just wondered if there's any, they're not here, but what's the success been?
So medicine is, oh, go ahead, you speak.
Medicine.
Baby.
Yeah, it's not really my baby, but technically one of my roles is the MD undergrad interprofessional theme lead, which is sort of interesting being physio, but we won't go there. And so what the way the medical curriculum is structured is they have these theme leads for things such as interprofessional practice that goes throughout the years. So my role is really to make sure that during the 4 years there are some interprofessional experiences embedded into there as much as they can do. So yes, they are involved, and yes, they do have a mapped out curriculum and milestones and so on that they have to meet in competencies throughout the 4 years. Having said that, it's extremely difficult because the medical curriculum is jam-packed. We would like to do, or I would like to do, them to do a whole lot more, but they have very strict guidelines as to, well, if you put more in, you've got to take something out. And you can imagine, and I'm being very honest here, you can imagine how you're end up with a discussion, a fairly heated discussion about, okay, we need to put some teamwork in, but you're going to have to jettison share of a bladder or, you know, whatever. Like it's a difficult balancing act to achieve. So certainly there is a commitment to it, and they have it in their accreditation standards, and they have to do it. I mean, there's no, there's no out for them. But the actual implementation is extremely difficult.
And just to add, to be fair to medicine, at the last curriculum meeting, there were 3 representatives from medicine.
Yeah.
And usually there's 2 of you that sit there in the last meeting, 3. So they're very committed moving this forward and trying to find ways to engage. But yeah, it might be a slow climb, but we'll get there.
Well, I'm just going to comment to that. I mean, Carrie, in fact, maybe the TIAS,
yes.
and was on the team committee meetings, and medicine never seemed to be able to, the beginning seemed to be able to get there, so we had some of those committee meetings. And then when it was TIAS, we were going out to do the teaching, the implementation didn't seem to be there. There wasn't that, the faculty wasn't there, sometimes the students weren't, depending upon what the teaching was going to be. So that our students never got an opportunity to really work. Pharmacy was there, social work would be there, dietetics would be there, OT sometimes did, but medicine in all the projects that I did in terms of
I think medicine is kind of late to the table, to be honest, in this game. I think they're getting there, but they're probably where we were several years ago, so there's sort of a catch-up. And it is definitely a cultural shift that's needed there. And as you know, that takes a long time.
Yes. So once again, thank you very much to the panels and this for coming. And to all of you, as token of appreciation and a coveted School of Nursing chocolate. Thank you.